Great. So if you have been to one of our meetings or trainings here at the Coalition before, we always like to record our sessions so that we can post it on our blog and make sure that you can reference the information later, point your colleagues to the key information that we're sharing. My name's Jody. I use she, her pronouns. I am a manager with the Coalition on Homelessness. We've got amazing folks here from Solid Ground. My colleague, Sarah and Rachel and Allison from the Coalition are here as well. This is Medicare, Medicaid training around public benefits are key. So one of the things the Coalition does is we really structure our work so that it's focused not only on the skills and the information that you need that's actually going to make a difference in your clients' lives, but also help just build resources for each other and to support service providers. So that is a huge part of what public benefits key are about. As Barbara just so eloquently put, this information changes all the time. It's highly technical. We've got experts here to help you navigate so you can share that information with your clients, because these are the resources that are actually going to make improvements in their lives, right? Benefits that actually make our lives better. As I mentioned, as we were getting people into the meeting, we have a post-survey training form. I've dropped that link into the chat for folks. We'll post it a couple more times, but we really, really appreciate this feedback. This is work the Coalition has been doing for years, and we are starting to expand and deepen that work, and we really want to make sure that it's meeting the needs and the information that you all need to do your work and do it well. As part of that post-survey, there's also a question in there if you are interested in having a little bit more of a one-on-one in-depth conversation with the Coalition around your experiences with public benefits. We would love to have that conversation with you. We are developing a listening session at the beginning of September for folks that have gone through this first series of training. So it was the ABD and HEN, age, blind, disabled, housing and essential needs. We did the second one which was TANF and Work First, so temporary assistance for needy families. And then we've got the Medicare, Medicaid that we're about to dive into. But part of this work is us understanding what is going on the ground for you and your clients, so we can pay attention to trends that are happening, and we can sharpen our advocacy and our work around making sure people are getting the benefits that they need and deserve. So on that note, closed captioning is available if you need that. That's that live transcript button down on the bottom of the Zoom screen. If you do not want to be included in the recording, just stay on mute, throw information into the chat. We will be sure to have nice breaks throughout each section to address questions or comments. I'm going to turn to my colleagues if there's anything I missed before we hand it over to Hannah. Hot dog, folks. All right, Hannah, the floor is yours.
All right, thank you. I am going to take a moment to share my screen, get our PowerPoint set up, just a moment. Make sure I'm not muted. Oh, sorry, I'm just trying to close this so it's not in the way. All right, well, welcome everybody. Like Jody said, my name is Hannah Rosenberger. I'm a benefits attorney with Solid Ground. I'm joined by my colleague, Will Ross, also a benefits attorney. He'll be speaking shortly. And then Sarah Robbins with the Coalition. And we're going to talk today about Medicare and Medicaid. Before we begin, we always like to just take a moment to recognize and acknowledge that public benefit laws and policies, including those around Medicare and Medicaid, they are steeped in systemic racism and are themselves, can be oppressive. So we're not going to talk in detail about those issues today, but we wanted to acknowledge it and name it and provide some links if anyone's interested in learning more about that. And then also just a reminder for ourselves or for the audience members to just be very, mindful and aware of stereotypes when talking about recipients of public benefits, because that can be very harmful. And again, sorry, I think a truck is about to go by my window. I will close that shortly. Just some additional links if anyone's interested in reading more about that. So this is a list of the topics we're going to cover today. We're going to break down the different types of Medicaid. There's a couple different programs that actually make up Medicaid. We're going to do a brief overview of Medicare and a Medicare savings program, which can help pay for Medicare-related costs. We'll talk about challenges with long-term care and also benefit pitfalls, things that can go wrong and how to avoid them. And then we'll talk about if something does go wrong, how to appeal that and what your rights are. And then we'll provide information about how to refer cases or clients to us at Solid Ground. And like Jody mentioned, at the end of each section, we'll have a pause for questions. So you can put questions in the chat and then we'll review them at that time, or we'll invite people to come off at mute. If for some reason we don't get to your question or you have something more specific, at the end, we're going to provide a special email for our Ask a Lawyer program so people can ask more specific questions. All right, so at that point, I'm going to hand it over to my colleague, Will.
Thank you, Hannah. I'm Will Ross, and I am one of the attorneys for the Benefits Legal Assistance Program, and I use he, him pronouns. So I'll be starting us off with the first part of this presentation. And just to begin with, I want everyone to know that the terms Medicaid and Washington Upper Health are one and the same. So you will hear sometimes it'll say Washington Upper Health, sometimes it'll say Medicaid. It's all the same thing. Next slide, Hannah. Now, in terms of Medicaid, there are two different Medicaid programs. The first one is called Magi Medicaid, which is for adults, children, families, and women who are pregnant. And often you would think of this as being, families would be on TANF would fall in this category. What Magi stands for, it means the Modified Adjusted Gross Income, and which is a person's adjusted gross income, and which is listed on their tax form, and plus or minus some other types of income. And the second type of Medicaid is called Classic Medicaid, sometimes called non-Magi Medicaid. And this is the Medicaid for people who are getting long-term care services or for people on ABD, age, blind, and disabled. Again, Classic Medicaid is for people who are aged, blind, or disabled. As a quick view between of Magi and Classic Medicaid. Magi Medicaid is for a person who's under 64 years of age or younger. They're not eligible for Medicare. They're low income. They're children, they're adults, they're pregnant persons, and they're parents and caretakers of Medicaid eligible children under the age of 19 years of age. And the Classic Medicaid, again, is low income, who meet one of the following conditions. They're over the age of 65, they're blind, and they're disabled by Social Security Administration standards. So who can get Medicaid under the Magi program? I already mentioned, pregnant women, children under the age of 19, parents and caretakers of relatives. That is, people who live with their own child or grandchild or another relative or step relative who's under the age of 18, or if they are full-time students, that child can be up to the age of 19. It's also eligible for childless adults between the ages of 19 and 64, including disabled individuals who are not on Medicare. It's also available to those who are on a family planning service program through DSHS. So what kinds of income will count towards determining a person's a Magi income in order to be eligible? It would be earned wages, taxable interest, dividends, unemployment benefits, pensions, RA distributions, alimony, income from self-employment, state income tax refunds, but not federal tax income refunds, rental income, and Social Security benefits. And that's true even if the benefits are not taxable. And the income that does not count towards MAGI Medicaid eligibility would include workers' compensation, veteran administration benefits, child support, certain scholarship income, American Indian income, or gift or inheritance money, which makes it significantly different than a lot of the other benefit programs, which would be counting gifts or inheritance money as income. And I won't go through all this, but this is a chart and which will be provided to you, which does outline what are the federal poverty level limits for MAGI, depending on the kind of program that you're in. As you can see, for new adults, the standard is 133% of the federal poverty line. For pregnant persons, 193. Apple Health is 210%. Apple Health for kids, those that his parents are paying a premium of $30, it's 312, and for family planning, it's 260. Next slide. And does the MAGI allow deductions from income? It most certainly does. Allows deductions for alimony payments, certain moving expenses, student loan interest, self-employed health insurance contributions, self-employment tax, RA deductions, and money contributed to a flex spending plan. Now, the big issue is whose income is counted to determine MAGI. Income is counted for everyone in the Medicaid tax household. And I want to emphasize that medical tax household does not necessarily mean everyone who's in the household, which I'll explain later, because not everyone's going to be an applicant. It's going to be on the application for the Medicaid. A Medicaid tax household typically consists of the applicant, their spouse, and dependents who are required to file tax returns. Again, it says this is not the same as the applicant household. So, one can have a roomer or boarder living in one's house. One would say that the person is a member of the household, but they would not be a member of the person's Medicaid tax household. And of course, like all rules, there are exceptions. And one of the big exceptions is the income of children whose are claimed as dependents by their parents. So if a child has enough income that requires that child to file a tax return, then that child's income is counted as part of the household. And that right now, that amount would be an annual through employment would be $12,550 or more. And if it's unearned income, it would be $1,100. Now, if the child is not required to file a tax return, then the child is not counted in the household. And this is true even if the child chooses to file a tax return. And you'll see this, often with in a lot of households, particularly with teenagers, the children have summer employment. So I'm going to open this up. I do have an example here, and we'll keep it up for a while so that everyone can have a chance to read it as well. So my sample is Jake and Kimberly Whitney are married with two mutual children, ages 11 and 15. Kimberly has a 17-year-old son from her previous marriage that lives with them. Jake's 18 and 20-year-old daughters live with them as well. Jake and Kimberly own a landscaping business. Their 15-year-old child works full-time for their parents in the summer, earning $4,000 for the year. The 11-year-old receives $110 a month in Social Security benefits. Kimberly's 17-year-old son receives $8,000 annual in tribal money. Jake's 18-year-old daughter is at UW on a partial scholarship and works part-time, earning $1,100 a month. And his 20-year-old daughter has just graduated from college and is about to start her first full-time job. So I'll open up for people to tell me who you believe income should be counted. I'll give you a couple of minutes to think about that. See, one person is 11, 15, and 17-year-old child.
We have a response from Chloe in the chat. Well, I can read that. Actually, I'm sharing my screen. I'm sorry, so everyone can see it. Chloe says the 11, 15, and 17-year-old.
Yeah, I think that's what I just read. Do you have another one? Okay, I'm gonna move to the next slide, which will explain it. Well, Jake's and Kimberly's income from their business is included as self-employment. The 11-year-old SSI income is going to count. The earned income of Jake's 18-year-old daughter, because she's under the age of 19 as a student, her scholarship money would be excluded. But she is included because she's under the age of 19. The 7-year-old son's income is excluded because it is money from the tribe. The 15-year-old son's income is excluded because he earns less than $12,550 and is not required to file income tax. And the 20-year-old daughter's income would not be included, and she would need to be eligible for her own separate Medicaid case. So does everyone understand how I reached that? Next slide.
Will, can I say one thing? Yeah. I think, you know, what the moral of this story is, it's complicated.
Yeah, right, I was gonna do that.
Very fact dependent. And, you know, this is the kinds of questions and scenarios that we have these wonderful attorneys at Benefits, legal assistance at Solid Ground to help with. We're giving you the overview of, you know, what's involved in looking at the eligibility, but we have the experts here that you can always call on to help with it.
Yeah, and sometimes it can get more complicated depending on the immigration status of certain members of the household, whether or not a child is actually being provided and cared for by another parent. So it really gets really convoluted. So this is just an example so I could show you all the things that you had to figure out. And it's not going to always be all that simple, as easy as Sarah said. So if you have any questions, feel free to contact us. And there is a kind of an ambiguity in terms of the assets limits for Magi. And if you look at a lot of the stuff that comes from the Healthcare Authority and from DSHS, it will say, oh no, there's no access limits for Magi Medicaid. well, that's not really quite true. It is based on SSI standards. One reason for the ambiguity is that, and I also want to say eligibility for Medicaid is determined for 12 months and will not change if the recipient's income increases during the eligibility period. I think I skipped ahead. I think I was answering your questions there, your slide. Yeah, so, but there is this asset limit to match. Next slide. So yeah, so this is mine. So the Magi Medicaid asset limit is based on SI standards with a caveat. And that caveat is that the Affordable Care Act simplifies Medicare eligibility enrollment for, it should say Medicaid eligibility for enrollment for millions of Americans. Qualifying with Magi simplifies the application process. The administrative burden of identifying assets is set aside. Although this is not true if you're seeking long-term nursing home care, or if you're seeking cash or food benefits. So if you're applying the Washington connections, you're going to have to report all your assets if you're applying for cash or food benefits. So as a consequence, because there isn't this, because the application process has been simplified and the administrative burden of identifying assets has been set aside, and consequently access-rich people, especially those with investments or real estate, may still technically meet Magi criteria. And so the reason why I'm bringing this to your attention is don't second guess and say, I think my client has too much in assets. Still apply anyway. Now, most Washington Medicaid members will be enrolled in an Apple Health managed care program. And what that means, managed care means that you have a set of doctors networks to choose from, which means that your doctor and specialists are more likely to have a line of communication with each other, and you're more likely to get the best care possible, so they claim. And there are 5 plans, and they're not all available in every area. So you have to, so depending on the area, and you may only have 2 options or 3 options. All Washington Medicaid plans include the same basic benefits. But each of the 5 programs offers little different extras in order to try to convince you to join select their plan over another. And so some of the samples of the extras that may be included may be a free cell phone, free boys and girls membership, GED testing, electric breast pump, acupuncture treatments, and rights to medical appointments. So if you're going to decide on which is the best managed care program, you need to look and see what are your client's needs are. If you have a client who wants to have some non-traditional medical treatment, then you may choose one that has acupuncture treatment. Obviously, if you have a client who has no children and plans to have no children, then the ones with the Boys and Girls Club membership will probably not be the one you'd be selecting based on that, unless they offer other things like rights to medical appointments and things of that nature. Next slide. And these are the 5 separate managed care plans that are in the state of Washington: the AmeriCare Group, Coordinated Care, Community Health Plan, Molina, and United Healthcare. Next slide. So how do you decide to choose which is the best MCO for your client? As I mentioned earlier, one of the things you want to do is you want to determine the specific medical needs of your clients and the individual needs of each family member, and also any foreseeable medical needs that you and your client are thinking about. Should also look outside of their medical issues and determine what resources or assistance your client could utilize to improve their wellness. And some of those examples are, if your client's disabled, they may benefit from a plan that has a disability advocacy program. And if they are large expanding families and there's some dynamics in terms of raising children, then you may want to pick a plan that has family coaching. And obviously those are not what you would think of as medical needs, but these are some of the services that some of these programs do offer. And then the other way that you can do this is, and it may be confusing because you see that, if you're applying for like TANF, quite often you will apply for Medicaid when you're applying on Washington Connection. But Washington Connection does not give you the opportunity to select what your managed care program is going to be. So one of the things you can do is you can go to the Washington, you can go to Medicare Plan Finder, and I've put that down for there. And they have what they call the ultimate guide in describing all of the MCOs, so you can see what the extras are. And the other thing which I highly recommend that you do is that you utilize the Healthcare Navigator, which can be found on Washington Plan Finder, and that is link is there, Washington Health Plan Finder. And I would also recommend that also be where you do your application, if possible, is on Washington Health Plan Finder. Next slide. And so this is just what the Navigator page looks like. You just put in the organization you belong to, the person's name, zip code, and then they will screen out which programs are available in your particular jurisdiction. Next slide. So as already alluded to, how to apply for Washington Apple Health. If you apply for or renew your Apple Health coverage, if you are an adult between 18 to 64, you're applying for children, you're a parent or caretaker applying for children, or you are pregnant, you can apply for Medicaid coverage through the Washington Connection, particularly if you're applying for, as I said, other benefits like SNAP and TANF. You can also call the customer service number, which I have here. You can also apply for Washington Health through the Washington Health Pathfinder. And I've listed various ways that you can do that. You can go online. They actually have a mobile app that you can download. You can call them. There's a paper application. And you can also do an in-person application through one that Health Benefit Exchange Navigators. And these are people who have been certified by the state who can assist people in determining what is the best health plan for them. Next slide. And so when you do apply, this is what you're going to need to have readily available. Your household monthly income, immigration information, if that, the date of birth for each member of the household, and also social security numbers of each individual. And then I have put down some exceptions where, and the most important exception where you may not need to provide social security number, and that is domestic violence survivors. Oh, and another note, if you apply online, you will you also will need to, you and your client will have to pick a username and try to find a password that everyone can easily remember. One that headaches, which I can often get, is that the client has applied before, but we can't access their account. We have to start a whole new one because no one can remember the password. Questions? I know that's, I went through a whole lot. Yes, I see a question. Can clients switch plans if they feel there's a better option for them? There are enrollment periods. And usually that enrollment period is like in November, December of the year. So they apply to January, then they're basically gonna be stuck unless there's some particular reason why they have to switch. But usually you have to remain there until the enrollment period, when there's a new enrollment period that starts.
Well, we have another question in the chat. I'll read that. What's the eligibility criteria / timeline for access for undocumented folks?
For undocumented people, that's a completely separate Medicaid program, which we have not gotten into. But there is one specifically for in the state of Washington for individuals who are not documented. And you can apply for that when you go on Washington Connection.
Yeah,
Okay.
so the current program that we have for folks that are undocumented is a very narrow, there are very narrow scenarios that people can apply for. So children that are undocumented qualify for Children's Apple Health. Pregnant women can qualify for pregnant women's care that extends for, I believe it was just extended for a year after the birth of a child. And then there are certain, for certain chronic conditions, I don't know them off the top of my head, there is an emergency medical condition or emergency medical program that folks can apply for, but it's a very narrow exception. We can share after this, I don't have we didn't include it as part of this, but there is some new eligibility under outside of Medicaid, but in our general health plan finder system that are some of those healthcare plans that are now available and tax credits that are available for folks that are undocumented. And we can share that out after. That was something that just happened this last legislative session, but we can put that information together and send that out.
We have a few more questions in the chat, so I'll read those. Would a major life event, such as marriage, divorce, pregnancy, etc., allow to change plans outside of the enrollment period?
Okay, can you repeat that for me, please?
Yes. Would a major life event, like a marriage, divorce, or pregnancy, allow someone to change plans outside of the enrollment period?
Yes, I can, but it's very limited. So I have to know, we'll have to know exactly what those major life circumstances are. But that can have an impact.
So I actually think, so the question around changing managed care plans while you're on Medicaid, I think we might have to follow up with that question afterwards, because I do think that they're for Medicaid as opposed to Medicare, which is different. I think that it's a little bit more flexible. Yeah. To change plans. So let's, unless I can find it right here, I think under Medicaid, you're entitled to change your plan as needed. But we'll follow up with a definitive answer after the training.
We still have a few more questions. So this next question is, are there any barriers for pregnant trans men in accessing based on pregnancy?
I think the terminology says a pregnant person. So can you read that question again for me?
Sure. Are there any barriers for pregnant trans men in accessing based on pregnancy?
There should not be. The state does have anti-discrimination clauses based on gender identification. And the language says, it says pregnant persons. It doesn't say pregnant woman.
There's one more question in the chat. How are income changes considered? Does the state periodically check with clients to see if any income information has changed? Or is it up to the client to report these changes? What, if any, are the possible repercussions if a client does not disclose income changes?
Can you go back to a previous slide? I think I skipped that slide. The slide should read, you are deemed eligible for a 12-month period and will not change the recipient's income increase during the eligibility period. So, 3 months after when it's approved for Medicaid and your income goes up, that will have no impact. It will have an impact 9 months later when you have to renew your eligibility, but will not have an impact during that 12-month period that you have been deemed to be eligible. And the question regarding citizenship, the two programs are called medical care services, and the other one is called alien emergency medical. The state does have some long-term ones. For the AMM, it is usually things like for dialysis, cancer treatment, certain kinds of surgeries. And one of the caveats too is that one program does have a federal restriction and the other one doesn't. And one of those federal restrictions is that you have to wait 5 years before you can be put on Medicaid. But I'll provide a more detailed explanation post-training on those two issues, on that issue.
All right, well, I'm not seeing any more in the chat, and I am also being mindful of time because I know we have a lot to cover. So I'm going to recommend we move on as the slide shows for the next section.
Great. Well, I am going to talk about the classic Medicaid. So this is specifically for folks that are 65 or older, or disabled, blind, someone that is on SSI. And this is also the program that someone would be on if they were on aged, blind, or disabled, or housing and essential needs, so ABD or HEN. This is sometimes called the categorically needy program, or CN medical. It's also referred to as classic Medicaid. And really the way to think about this is prior to the Affordable Care Act and what we often think about as Obamacare. This was the only Medicaid program. So to qualify for Medicaid previously, with some exceptions, you generally had to be on SSI, be on the aged, blind, or disabled program, have a disability, be over the age of 65, and then a few other exceptions. So that's really the way to think about this program. And the income and resources that apply to this program are the same ones that apply for SSI. And we have those on another slide. Next slide. So this, again, provides coverage to individuals who meet the SSI income, resource, requirements, and then one of the following: aged, meaning 65 and older; blind, as defined by Social Security; disabled, again, defined by Social Security or determined by DSHS. And this is the ABD folks are covered under that. And here are the SSI and also the categorically needy or classic Medicaid income limits. So for a single individual, someone cannot have income over $841, which is the monthly amount that someone would get on SSI. And SSI currently has a resource limit of $2,000 for an individual. And then it shows you there what it would be for a household of 2. Next slide. How to apply for categorically needy. So when a person is approved for SSI or ABD, they might be auto-enrolled, but oftentimes the systems don't talk to each other. SSI is going to go through the Social Security Administration at the federal level. The aged, blind, or disabled program is going to go through DSHS, and all of the Medicaid programs go through the Healthcare Authority. So really confirming that clients that are on these other cash benefits are also receiving Medicaid is key. And if they aren't, they can apply through DSHS's site, Washington Connection. They can apply through Health Plan Finder. Do we have Health Plan Finder on this slide?
I realize we do not. The Health Plan Finder information is on some earlier slides if people need to see that.
Yeah, so we have another slide that has Health Plan Finder, which is the main way to apply for Medicaid. Next slide. Oh, there we go. And Jody just dropped that link in the chat. Any questions on the classic Medicaid? Otherwise, I will turn it over to Hannah.
No questions yet in the chat, so I will move us to the next section. I think I turned my video on. Yes, okay. So I'm going to talk about the medically needy program. So this is, again, another Medicaid, another way that individuals can access Medicaid coverage. The medically needy program provides Medicaid healthcare coverage for aged, blind, or disabled persons, people who are institutionalized, hospice individuals, pregnant, I'm sorry, that should say pregnant people or individuals, not women, children, and refugees with income above that categorically needy standard that Sarah was talking about, and countable resources below the medically needy resource standard, which I'll have a slide in a moment. An individual may qualify for this program with or without a Spendown, and I will explain what a Spendown is. So eligibility for this program, again, it's someone who's blind, aged, pregnant, has a disability, is a child or parent of that minor child. The income has to be too high for regular Medicaid eligibility. And this is kind of the meat of this program. The individual has medical expenses significant enough that when subtracted from the person's income, it brings the after medical expense income down to a level that the state deems eligible for this program. And I'll give you those dollar amounts in a moment. And then you do also have to have limited assets, so typically around $2,000 for an individual person. So the idea of this program, it's called medically needy because it's for people who have such high out-of-pocket expenses that even though their income might be higher, after everything's said and done, it actually brings their income down significantly. So you might have a client that's getting Social Security disability or a pension, but is still eligible for this program. So this is the medically needy income and resource standards. So there's not necessarily a hard and fast income limit for the medically needy program, but the more income you have, the more you have to spend out of pocket before you're eligible to get this coverage. So there is a monthly income standard. You can see that in the chart to the left that increases based on household size. And this is the minimum amount that is set that the government determines that everyone should be able to keep from their income to care for their daily non-medical needs. And then any amount above that standard is going to be counted as income. There are some deduction rules, which I'll get into shortly. And then the chart to the right shows the different resource limits. So how this program works, if you're eligible for the medically needy program, you can get Medicaid coverage once you incur a certain amount of medical expenses during a specific period. And that amount is called the spend down amount, or just spend down. So you might be working with a client who says, you know, spend down, I have a spend down, I have to spend money. That's probably talking about the spend down. Excess income is the amount of your countable income that exceeds the amount of your income set aside for non-medical expenses. So that's that $841 that I mentioned. The amount of the monthly excess income you have, that is what is used to determine your spend down amount. And I will have examples in just a few slides. So I mentioned that you have to incur a certain amount of expenses during a specific period. And that period is called your base period. So it's the time used to calculate your spend down. And it's either going to be 3 or 6 months. And DSHS calculates the spend down amount by multiplying the number of months in the base period by the amount of your excess income. So just as an example, let's say you have someone who has $40 of excess income and they have a 3-month base period. So their spend down amount is going to be $120. And once they've incurred $120 in medical expenses, then they can start getting Medicaid coverage. And then at that point, Medicaid will start paying for their expenses instead of the provider sending the client the bill directly. And I'm going to provide a more detailed spend down example. Spend down, it can be kind of confusing, and sometimes you have to look at it a couple times to get it. So this example looks detailed. I couldn't get the numbers even because, well, 841 isn't an even number, but we will provide the slides after this presentation is done. So hopefully this slide can just be a good reference for everyone. So this client, Sam, gets $1,200 a month in Social Security disability benefit. So this individual is going to get, just right off the top, a $20 deduction for unearned income. So the countable income that DSHS is actually going to look at is $1,180. Sam also gets to subtract that $841 from that amount. And that's you may notice that that's actually the same as the SSI amount. So that dollar amount changes every year. So Sam's excess income is $339. So if Sam chooses a 3-month base period, their spend down amount is $1,017. So as soon as Sam incurs medical expenses or bills for that amount, they can start getting Medicaid coverage, and Medicaid will pay the bills for the rest of that base period, for the rest of the 3 months. Just to note, if somebody's working and getting wages, the calculation is going to be slightly different. The deduction is a little bit different than just that 20 for unearned income. But again, if you have a specific scenario or questions, feel free to reach out to us. And the client does need to submit copies of their bills to DSHS so that DSHS knows that they've been incurring these expenses. We always encourage clients to make copies keep the originals and just give DSHS the copies. So just some things to remember about the spend down. The spend down and the spend down period and the eligibility period is 3 to 6 months. It's either 3 or 6. So if our recipient has a 6-month eligibility period that starts in January, then they have to meet their spend down amount before June. And Medicaid will pay the remaining balance of medical expenses through the end of June. But come July, they're in a new eligibility and a new spend down period, so they have to start incurring those expenses again. And then the client submits copies of these bills to DSHS to go towards the spend down. They can fax them, bring them into the office, or mail them in. But again, we just recommend clients keep their own copies in case something gets lost on the DSHS end. And this is a really important thing to remember about spend down. The medical bills do not have to have been paid, just incurred. So as soon as the client gets the bill in the mail, they've incurred that legal obligation to pay this, and it's been incurred. So they can submit those bills to DSHS as they get them. Medical expenses, which third parties are liable for, do not count as part of the spend down. So you might think if someone, their insurance company is paying for something, or if Medicare is covering a bill, that's not going to be able to be counted towards the spend down amount if it's not something that the client is responsible for. Oh, and just as a note, spend down can get, again, like we've been saying, complicated. So what counts for spend down, what doesn't? If anyone has specific questions, we can provide more detailed information or help on a case-by-case basis. But I just did want to note that generally these expenses do have to be prescribed expenses by a licensed provider. And I have an example, kind of a tip for advocates. If a client needs mental health care, but they're having trouble finding a way to pay for it, this is a time to remember that if the client incurs enough bills to meet the spend down, then Medicaid can start and that provider can start getting paid. So of course, not every provider will operate this way and allow a client to incur these unpaid bills until they are able to start billing, but it can be a creative way to help clients get mental health care that they otherwise wouldn't be able to. And then how to apply for this program. Again, the coverage for this program would be through washingtonconnections.org. And I provided the phone number, the website, and then there's a link if you need to find your in-person office. And then once somebody applies and is approved to receive this, they have to submit proof of those medical expenses to DSHS. And then again, as soon as they meet their spend down, then they'll actually be enrolled and covered under Medicaid coverage. So we're at the questions. I'll see if anyone has any questions so far.
Yeah, Hannah, there's a couple in the chat. What if the client cannot pay their incurred bills?
So for it to count towards spend down, they don't have to have paid it. They just had to incur it. So of course, the provider, they're gonna do what they do with unpaid bills, but the client can still use that to count towards spend down. And then if they meet their spend down, then Medicaid will cover, and then the provider can start billing Medicaid directly. So that might not be a perfect answer, and if anyone else has any other thoughts, but that would be my answer.
I think that's correct, Hannah. But then also too, one can always petition for charity cases to pay for some of the unpaid hospital bills. And we have worked with clients to try to get their medical bills reduced or eliminated.
There's a couple others in the chat. I want to say one on the incurred bills. The other scenario that I have often helped people, strategically plan for a spend down is if someone has has this little bit higher level of income, doesn't automatically qualify for Medicaid, but they know that they need some type of very expensive surgery or some very expensive equipment that they can't afford on their own, and they want Medicaid to pay for. Sometimes it is worth, incurring or sometimes even paying a spend down amount of, say $1,000 in order for Medicaid to pay. I've had people do that and plan things strategically so that they can get, a bunch of dental work done that's like $5,000 or $6,000 of dental work, and then get, particular types of medical equipment at the same time, and have, a particular procedure that they need done, and just try and plan it so that your out-of-pocket expense is your spend down amount, but you're getting, thousands of dollars covered in actual medical care.
And I do see-
I was just going to read the next question. Yeah. So the individual is responsible for submitting all of the bills, or are they automatically submitted to Medicaid?
Yes, so the client does have to submit the bill to DSHS, or else because the provider is not billing Medicaid, DSHS wouldn't have they wouldn't know. So sometimes I have some clients that at the beginning of each spend down period, I send them a new folder, like a organizational folder, and they start putting the bills there, and then we check in with each other to see if they have any bills to submit, and then help them submit. So it is something that clients may need additional assistance with. And again, they could submit them by dropping them off in the office, through fax, or mail. And a tip is, you want to write spend down everywhere, on your cover sheet, on your letter. You want to make sure that these bills get to the spend down unit, or else they might just be added to the client's file and then not actually kind of put in the right folder or file for that client.
And I just want to reiterate something that you just said, Hannah, because I had this experience where a client had both a spend down and she also had SNAP benefits. And so she was, this was the pandemic, and she would go into the office and she would bring her bills, but they were only copying so many of the bills, and she was unaware of that because she didn't know there was a difference. They copied only so many bills because it met the maximum in terms of her deductions for the SNAP benefits. But there were far more bills that should have been applied to her spend down, which were not applied to her spend down. And she was completely unaware that the worker she was seeing was only applying it to her SNAP benefits and not to her Medicaid. So that's something also to really emphasize, because not every person at DSHS that your client is going to be coming in contact with is going to understand what they're supposed to do. And so it's really important that, as Hannah said, that every communication says, this is applying to the spend down. Please apply this to my spend down.
Yeah, and I think if, Alyssa, you kind of read my mind, which is, if folks don't have that level of support or organization to send in their incurred bills, does the system have any supports in place to help navigate, such as a case manager that could be assigned to check in? Unfortunately, within the DSHS system, no. But this is something that the folks at Benefits Legal Assistance, so Hannah and Will, are very good at helping clients. So if you have clients that are, regularly trying to meet their spend down, connecting with one of them I will also offer that we can also set up a smaller group training. If you're at an organization where you have many clients that are in this scenario, I know some of the permanent supportive housing providers, you probably have many clients that are in this position. If you work for a mental health organization, you have many clients that are in this position. We could organize smaller group trainings to really train case managers on how to do this with your clients. I mean, this is a very sort of introductory, what are the basics of a spend down? But we could do something if people were interested, in a smaller group of really how on a day-to-day basis you can help clients with this. And I think, let me just check and see if there were other questions. Jody asked if, other than charity care, is there advice about how to talk to clients about incurred bills? Yes, and it depends on a number of circumstances. There are clients, depending on what their income source is, that are what you call judgment proof. So even if bills went to collections or someone got a judgment, there wouldn't be any way to collect. Now, obviously, that's not ideal for someone that needs to preserve a credit score for particular things. So there are things that both benefits attorneys can talk with clients about, but also there are consumer law attorneys that do regular clinics on this kind of stuff that can give people advice about these types of outstanding bills.
Great. We are doing pretty well on time, folks. So, and I'm just wanting to highlight, as someone that doesn't do this work, so maybe this makes better sense to the rest of you, but I am just really repeating in my mind, like I would be calling Will and Hannah all the time. I'd be emailing all the time. So as we move into the next part of Medicare, I know Hannah and Will are gonna cover this later, but let's just repeatedly, we all have COVID brain or pandemic brain. I'm going to put some of those resources to connect with them into the chat, and I will hand the floor back over to, I think it's Will. So thanks, folks.
You are muted, Will.
Thanks for saying that, Jody, because when I was answering the questions, I was looking at the criteria for the medical spend down program. So in terms of the question is, when can you change providers? I'm putting the answer down how to do that right now. So we do not do Medicare at BLA, and I thought, however, that in order to really understand the MSL, the Medicare Savings Program, Medicare Savings Program, you have to understand just a little bit about Medicare. So this is going to be a really quick overview of that program. So Medicare is a federal health insurance program where Medicaid is managed by the states. Medicare is strictly a federal health insurance program. And it's for people who are 65 or older, certain younger people with disabilities, people with end-stage renal disease, permanent kidney failure requiring dialysis, or a transplant, which is sometimes called ESRT, and recipients of SSI. Unlike Medicaid, Medicare does have a premium cost. Next slide. So who can get Medicare? I think I mentioned some of those. But it is for And people who've worked under Social Security or railroad retirement systems get over the age of 65, have been receiving Social Security or railroad disability for at least 24 months, need dialysis, need a kidney transplant, are receiving SSI, they meet the citizenship and alien status requirements, and are age 65 or older, or can draw Medicare based on having worked a sufficient amount of quarters during their lifetime, or they can also get it through a disabled parent. And there are 4 parts to Medicare, and this is where the MSP comes into play. Medicare Part A is hospital insurance. That's exactly what it covers. It covers inpatient hospital stay, care in a skilled nursing facility, hospice care, and some home health care. Medicare Part B, that's what covers your doctor services, your outpatient care, medical supplies, and preventive services. And Medicare Part D is for prescription drugs. Most people have no premium for Medicare Part A. The standard for premium for Part B is $170.10. It can go higher depending on one's income. And for Part C, the monthly premium varies by plan. And so I provided that link so you can see what that is. And for Part B, the monthly premium will vary by plan, and higher income individuals are going to pay more. And you can compare the same link I had before. Part A is free for people who have worked, have earned the required number of work quarters within a certain time frame, have a spouse who's earned the required numbers of work quarters. Part A is also available at a cost for Medicare entitled individuals who do not have the required number of work quarters for free Medicare Part A. And everyone who enrolls in Part B must pay a monthly premium. And I won't get into a whole lot of this, but this is an optional supplemental health insurance. And so you probably would hear when a client says they're on Medicare Advantage, and Medicare Advantage is Part C. And those who are on this program, they must pay a monthly premium in addition to the premiums they're paying for B and A if they have to. But there are some Part C plans in Washington do not charge a monthly premium. And Healthcare Authority at one time was paying for Part C premiums. They're not doing that anymore. And I'm just going to like flip this slide so for one particular of interest. This is regarding prescription drugs. And this is where the issue of dual eligibility is going to come about. Some clients are going to be automatically enrolled, are eligible for Medicaid and Medicare. And these people should be paid no prescription costs. Next slide. So it's now up to, can Apple Health pay for your Medicare premiums? The answer is yes, if you qualify for a Medicare savings program. And now it's yours, Sarah.
I think this is Hannah going to take over this. So like Will was saying, he gave us a good introduction into what is Medicare. And now I will talk about the Medicare savings program. So the Medicare savings program, if you're on Medicare, you may qualify for help with Medicare premiums, deductibles and cost sharing. I just realized I didn't turn my camera back on. Just one moment. There are 4 programs that can help, and that makes up the Medicare Savings Program, or MSP. And I just want to note that the Medicare Savings Program, it's not a separate medical insurance coverage. It doesn't actually provide medical coverage, but what it does is it helps pay for Medicare related costs. So I realized there's a funny typo on my slide for who's eligible. I said, if you reside in a state or the District of Columbia, which is accurate, you do have to reside somewhere in the United States. But if you want to get medical savings program in Washington, you do have to be a resident of Washington State. You are aged 65 or older, receiving Social Security disability benefits. People with certain disabilities or permanent kidney failure, and that's even if you're under age 65. So of course, not everybody who's receiving Social Security disability is over 65. So that's why there are people who are under 65 that could also qualify for this program. And then you do have to meet standard income and resource requirements. So I did want to note there is currently a resource limit. So it's $8,400 for an individual, or about $12,000 for a couple. Good news, this asset test is actually going to be eliminated early 2023. And there were a lot of health advocates, community advocates, legal aid advocates that worked for years on eliminating this resource limit. So that's an exciting legislative or an exciting policy change. And this is especially important for people who are living on very fixed income, and they either weren't able to save any money if they were on the, or save a significant or a good rainy day fund if they were on Medicare Savings Program, or someone whose income they would have been eligible because they were low income. They were excluded from this program because of their savings, which now, or at least shortly hereafter, that will change and more people will be eligible for this program, which is a great change because it really can cover and provide a lot of assistance for people. So there are,
Hannah,
yes, go ahead.
A question in the chat that I think we should probably just address quickly. And I think just defining what a resource is versus income.
Yes, thank you so much. And I realized as I'm going through this, I had notes about the resource and income limit, but didn't have a particular slide. So that's like a note for next time, but thank you for that question. So an asset or a resource, it is things like savings account, bank account, property, stocks, bonds, things that you can think of that are different than the money that you get every month from Social Security or from wages. That's income. Income comes from employment, Social Security. You can think of something like child support. So money that comes in every month, that's income. And then money that's saved or saved in bank accounts, checking accounts, property, vehicles. Those are things that are assets or resources. And the word assets and resource, they are the same thing. We're using them interchangeably. So did that answer the question? Hopefully that did. Thank you for bringing that up. All right, so as I mentioned, there are 4 programs within the Medicare Savings Program. I like to think of them as levels because depending on your income limit, you are eligible for a certain level of coverage or assistance. So the first one is called the Qualified Medicare Beneficiary, QMB. So this program is really the most robust level. It will pay for Part A if someone does need to pay for Part A. It'll cover Part B premiums. It will pay the deductibles and co-payments. There is a note, except for prescriptions, there are, like Will was mentioning, Part D subsidies and plans, and generally you see that being capped. So there's the possibility that someone may, depending on the medication, have to pay a very small prescription copay, but that could be like less than $3. So the second level is the specified low income Medicare beneficiary. You'll notice we have the acronyms because each level is kind of a mouthful to say. So this program pays Part B premium. The next program is called the qualified individual, and that also pays Part B. And then lastly, there's the qualified disabled working individual, and that will pay the Part A premiums. And I am going to provide some more details about each program. So the first one, as I mentioned, this is called the Qualified Medicare Beneficiary Program. Clients that are receiving QMB, we also call them dual eligible. So this is something Will mentioned earlier. There are certain people that are going to get Medicare and Medicaid at the same time. So they're dual eligible. They have income at or below 100% of the federal poverty limit. And just to note, that number, the federal poverty limit number, changes every April. So this year, the individual limit is 1,133. It's a little higher for a married couple. And then, oh, look, I did include those resource limit amounts there. So as I mentioned, this is the most robust level. And this is a tip for advocates. If you're working with a client that's getting Social Security and is on Medicare, and their income is less than $1,133, they should apply for QMB if they haven't already. And if you notice, this is something that I used to see with clients, I would notice that their Social Security check is about $150 less than it should be, or $170 less than it should be. And that amount is the Medicare premium, which told me that even though they could have been getting QMB coverage, they weren't. And so the Medicare premium was actually being deducted from their Social Security check every month. So if you run into that example with a client, you can help them apply for this program, or of course, refer them to us. And I just want to make another note. Someone who's getting QMB might also be told that they have a spend down from DSHS, because as you notice, that dollar amount, $1,133, it's more than that $841 we talked about in the spend down. But because they're QMB and dual eligible, Medicaid is already covering the gap. So I have clients that they are QMB, and they're also told that they have a spend down, but they don't necessarily have to try to meet their spend down because they're already getting that dual coverage. So that's just something that you might see. And just a note, other Medicaid programs do have retroactive benefits. So if they were eligible, but maybe they were late in applying, QMB does not have that. So there won't be any retroactive benefits, but as soon as they're on it, they can start getting that assistance. The second program I mentioned, the SLMB, this is if you are at 120% of the federal poverty limit. Just pause for a moment so you can see what those income limits look like. The next program is the qualified individual level. Just as a caveat, you cannot access this if somebody is qualifies for Medicaid. So that might be somebody, their income is at or below 135% of the federal poverty limit, and they have a spend down, let's say. So if they haven't met their spend down, they're not on Medicaid, so they can still get help covering their premiums. But when they meet their spend down, if they get on Medicaid, at that point, they're not going to get help paying their premium, so they will have to pay those at that time. And then you can see the income and the resource limits there. And we wanted to mention some recurring issues that we see with clients who are on the QMB program and medical providers. So there's actually federal law that forbids Medicare providers and suppliers, and that includes pharmacies, from billing people in the QMB for Medicare cost sharing. So I don't remember if we said this before, and I apologize for saying it so late. Generally, Medicare covers 80% of your bill. And then the client has 20% that they have to share, that they have to cover. That's the cost sharing. When somebody gets on QMB, Medicare is going to step in and pay that 20%. So Medicare beneficiaries that are enrolled in QMB, they have no legal obligation to pay those other deductibles, coinsurance or the copays, as long as it's a Medicare covered item or service. But dual eligible clients are still often wrongly billed. So if you have a client that is on QMB and they keep getting a bill from a provider or a pharmacist, feel free to reach out to us and we can help them resolve that issue, usually by sending a strongly worded letter and follow up to the medical provider that keeps billing our clients. There's also, oh, you know what? I think I already mentioned this, but this is an issue unique to the qualified individual program. So unlike the two other programs, one cannot be enrolled in other government-funded medical programs while on QI1, the qualified individual program. But they are able to be on Q1 and a Spendown. So again, once the Spendown is met, they get enrolled in medical and they're terminated from the qualified individual. But until that's done, they can still access this help paying those premiums. And if anyone does come into any issues with how DSHS is calculating the spend down or premiums, you know, you think someone should be eligible for Medicare savings program, but they're denied, again, definitely refer and reach out to us. So lastly, the last level or program under the Medicare savings program is the qualified disabled working individual. So this is specifically for individuals who had Social Security benefits and Medicare because of a disability, but they actually lost those benefits because they went back to work and now they earn more than what Social Security would allow them to earn. So this is going to be someone that has income at or below 200% of the federal poverty limit. And you can see what their those income limits and resource limits are. Right. So when sometimes clients do ask us, you know, should I use this provider? Should I do a Medicare supplemental plan? We aren't able to provide that kind of information or advice. It's outside of our scope. But what we do is we often refer people to the statewide health insurance benefits advisors, or SHEBA. So SHEBA, they provide free, unbiased, and confidential help with Medicare to people of all ages and all backgrounds. It's made up mostly of volunteer advisors, and they can help with this whole list. I won't read everything, but generally they can help clients evaluate and compare Medicare programs. They can help determine if they might be eligible for one program over another, and they can even help talk to Medicare on behalf of the client. So they're a really great resource. And this is the 1-800 number. And then I've also provided the website. And for King County specifically, Solid Ground, the organization we work, there is, they are running the SHEBA program. We have a volunteer services department that is actually facilitating that. So they're doing really good work. And this is the contact information for SHEBA. And then lastly, just how to apply for this Medicare savings program. It's pretty easy. Clients can contact the local CSO. Again, the WashingtonConnections.org website, people can apply on there. Or if they want a paper application, I've just included some of that information there as well. All right, so any questions that may have come up that we haven't already answered? I don't see anything in the chat. So if that's the case, I'll move on to the next slide, but I think we probably will have more time at the end if anyone thinks of anything else. So I will pass it back to Sarah.
One thing, we say that, the MSP does not pay for Part B, but one can apply to the federal government to see if they will help pay for on the Part D premiums. And this is called the Low Income Subsidy, LIS program. And one would have to reapply for that every January, unless they are a Medicaid individual.
Thanks, Will. That program, that low income subsidy Part D, is also a program that when someone is approved for Social Security, the Social Security Administration is supposed to do an eligibility evaluation at the time that benefits are approved and put people on that program. But if they don't, or someone becomes eligible later on, it's a good tip to apply for that low income subsidy. It saves people a ton of money in prescriptions. I am going to talk a little bit about long-term services and supports paid for by the Medicaid program. So Apple Health or Medicaid can help people pay for care based on both financial eligibility and also functional eligibility. Care can be provided in-home. So if people are still able to live on their own, but they do need some element of in-home care. Away from their home, they can provide pay for care in alternate living facilities such as community residential care facility, assisted living, an adult family home, or a nursing facility. Next slide. We know that it can be very challenging to find, to both qualify for long-term care or in-home care. And then also when people are approved, it can be difficult to find in-home care or a placement out of the home for someone to go, especially individuals with special needs, including developmental disabilities, particular behavioral health or mental health challenges, or substance abuse issues. While the attorneys at Solid Ground are experts in financial eligibility for long-term care, they are not the ones that do the functional assessments or challenges to denials of care based on those issues such as substance abuse or behavioral health challenges. But there are attorneys throughout Washington State that do take those cases. Outside of King County, someone would call the CLEAR line, the CLEAR legal line. If someone's over 60, they can call CLEAR Senior. It's a little bit easier to get through. Then in King County, Northwest Justice Project main phone number can be called for help with those types of things. CLEAR also has an online application. Next slide. More challenges in the long-term care arena. The labor shortage has definitely affected this sector as it has many sectors. A lot of people that especially worked in doing in-home care during the pandemic left that line of work, not wanting to go into homes, especially multiple homes a day. And the state, while it has a responsibility to help someone find a care provider, it can often be challenging. So I think helpful tips for all of you as advocates, you can work with the DSHS case manager. This is usually through a department called Home and Community Services, to make sure that they are continuing to search agencies and individuals to help your client find an in-home care provider. You can reach out to agencies and organizations that do long-term care to help find someone. And also, Individuals can have a friend, neighbor, or relative do in-home care if that person qualifies as a paid caregiver. In the next slide, I will talk a little bit about, so if someone wants to use a family friend or neighbor to be their care provider, that person has to pass a criminal background check. They have to provide picture ID, authorized to work in the United States. It cannot be the spouse of someone getting care. A spouse cannot be paid to care for their own spouse. They have to sign a contract with DSHS and agree to certain conditions. And then there's a training requirement. You can talk with DSHS case managers at Home and Community Services more about this. And we've also included, when we send out these slides, a link and a phone number to get more information or apply to become a service provider. Next slide. And these are community resources for folks needing long-term care. DSHS King County Home and Community Services. So this is the DSHS office that does all of the eligibility and referrals and case manages those that are on long-term care. Division of Developmental Disabilities. So if someone has a developmental disability and qualifies for care in that way, they would go through that DSHS department. Community Living Connection and Aging and Disability Services are both community organizations that can offer support around both the application process, the renewal process, and I don't know if they help provide, I don't know if they help people find providers or not, but it would be worth a call. All right, I think this goes over to Will, right?
Yes, it does go to me. So, so I want to discuss some of the benefit pitfalls. Because benefits can be denied or terminated due to income or resources. But sometimes it goes beyond just being benefits being denied. Quite often what we'll see that services or procedures or prescriptions can be denied. And so I just want to give you, some examples, the most common ones that we see. Now the healthcare authority may deem that a client's surgery is not medically necessary because they'll say, well, there's other less expensive procedures that could be done. They may say, well, the person can do 6 more months of physical therapy in order to correct a movement problem rather than having surgery. We often see that children's braces can be denied for a variety of reasons. And again, this may be that the healthcare authority is saying that they're not medically necessary for the child. And often we'll see prescriptions are being denied. And there's a variety of reasons for this. It can be that the drug is not being used for the purpose that it's been approved by FDA. I had a case where prescription was actually approved by FDA for one condition in a particular form, in an oral form, but it was helping my client with a different condition as a nasal form. And we had to get in what is called exception to the rule and get them to cover that. And sometimes you will see that, the doctor who is prescribing the medication, the prescription, is not deemed a specialist by a healthcare authority to be able to prescribe that prescription. And I can give you an example of that. I had a client who has a general practitioner doctor who has been treating clients for a certain condition for almost 20 years. But he's an internist, and he's not a dermatologist. And the healthcare authority was denying that prescription because the doctor wasn't a dermatologist, and we had to fight to get that done. In spite of the fact that this doctor's been working with these kind of patients for over 20 years. And the other thing is that the healthcare authority will deny a prescription because it's a brand name and not a generic, although we know that not all brand and not all prescriptions are the same. And the other big one we'll see is that there are time restrictions or time frames in which you can get medical services. So let's say that and I'm not quoting it, but for example, just trying to illustrate something. And let's say the healthcare authority says that you can only get hearing aids every 2 years, and they will pay for every 2 years. But your client has a medical condition where the hearing is deteriorating at a much faster pace, and they need to have those hearing aids replaced every year. And what will happen is the healthcare authority will deny the payment of that hearing aid because you're asking for it within a year, as opposed to waiting 2 years because you already have it. So if anything occurs, so I'm just trying to illustrate that it's not just services, it's not just a program being terminated, but quite often services will be denied or curtailed. Contact us, because there are ways of trying to remedy the situation. Next slide. So what to do if something goes wrong? Request a hearing. How you request a hearing, you can call or you can write DSHS or the healthcare authority or the Office of Administrative Hearing. You do have the right to be represented by an attorney, and I've listed the telephone numbers that you can call for DSHS customer service, healthcare authority, Office of Hearing Administration, OAH. And it's the Office of Hearing Administration, but we also refer as the Office of Administrative Hearings. And if ever in doubt, please, contact us. There are time restrictions as to when you can file a hearing. And those restrictions it's 90 days to request a hearing from the date of an adverse action. And sometimes it's really hard to determine when an adverse action is. Usually an adverse action is when a decision is made by the department and they put it in writing. And what I've had cases where my clients have actually called and they've been given the adverse action verbally. You should still file a hearing as soon as that occurred. You should also request continued coverage if they're still eligible. And that needs to be done within 10 days. There's some caveats to this. If you have a client that has a service that terminates after 12 months, then they're no longer deemed eligible after that 12-month time period if the adverse action was due to the non-renewal. And the other caveat too is that if your client does ask for continued coverage and it goes to hearing and they lose at the hearing, they are going to be required, let's say for ABD, they are going to be required to repay the benefits which they received, but it's only going to be for the first 2 months. And so if a hearing takes 4 to 5 months and your client's collecting ABD benefits for 5 months before a decision is rendered, they will only have to pay back the first 2 months. And again, you have to make this request within 10 days of the date of the DSHS notice. Next slide. So you have, so as a lawyer, and I really want to strongly emphasize that, particularly with these Medicaid, Medicare issues, because even I, answering the question was referring to restrictions of MSP and not to Medicaid. So you have a question about the process, application process, contact us. You have a question about eligibility, contact us. You have questions about qualifying for Medicare savings program, contact us. Or for Medicaid, and if your client has been denied a medical service or prescription, please contact us. And if you have, if you have a particular scenario that you're going through with a client, and please email us, and we will definitely respond to all those inquiries. And when you send those emails, put in the subject matter, ask a lawyer. So I just want to give you some information about our general referrals. We do have an intake line, which is 206-694-6742. And on Mondays and Fridays, we will be returning phone calls over 24 hours. And we're not listening to messages on Saturdays and Sundays, but we will get back to you on Monday. And then you can also use our general email, which is benefitslegalhelp@solidground.org. Or you can contact us directly. If you have legal questions, please contact Hannah or myself. If it's an issue regarding intake, if you want assistance with application, you can contact Hannah or I. You can also contact General Stark, who's our legal assistant. And you can also contact April Mesa on those issues as well. And I do want to make a notation that I did put down the LIS information, that is the paying for premium D, and in the chat. And I think I put down the if I haven't, for the healthcare for individuals who are non-citizens, I'll be putting that in the chat in a moment as well. Any questions?
Not seeing a question, but I did just want to, Sarah responded to this in the chat, but I think it's worth pulling it out for anybody that's not following the chat. What can we do when denial is happening for a movement issue and the doctor agrees that physical therapy will not necessarily fix with no surgery? Is that something we can request a hearing for? And Sarah was like, it's a great referral to an attorney, as Will already went over, but if anybody wants to add to that.
Well, I mean, I would say, do reach out to us. I mean, there's a lot of things, sometimes, sometimes it's the way that the treating physician writes up the information, sometimes it may require additional medical documentation to show why this is medically necessary. And so what one would do is, there is a procedure called exception to the rule. You'll follow that. Then one can also request a hearing as well. So there's a variety of different avenues, but I just can't, give a clear answer unless I have a specific case. I mean, I have had cases where I didn't have to go to hearing, where it was just getting additional information or talking to the healthcare authority and persuading them why this was necessary, or getting additional information for the doctor and then submitting that to the healthcare authority, and that has resolved the issue as well.
Great, thank you. Well, we have about 10 minutes left, so if there's questions that came up generally around benefits that you might want to ask, or you're not sure where it falls, or you've been thinking about something from one of those first couple sections, feel free now to come off mute or throw it in the chat. I will encourage folks to please fill out the post-training survey. This is really quite helpful for us. And this is our third in the series. We're wrapping up this round one of public benefits are key, and we are going to be launching the next series for September, October, November. So September will be ABD Hen, October will be TANF and Work First, and we'll repeat this one again in November. And this is a way that we can just make it really good for folks. So I'm going to throw that link in the chat again. And Alyssa, I see your hand, so please take the floor.
Yeah, I was just wondering for either presenters or other providers on the call if they've had experience with any particular plan, either through Medicaid or Medicare, like positive experiences providing like medical case management supports and care coordination to clients. It seems like most are pretty light touch, and finding that longer term support and care coordination for clients specific to their or their children's medical is really challenging. So just wondering if anybody has recommendations or any plans that they've seen do a good job of doing that, and not just like a scheduling a one-off appointment, but really more in-depth coordination for folks.
Well, I would say we usually get into all those weeds, and we don't make recommendations. But again, I really would stress, because at one point I was the program manager up at a residential housing. So I really do, again, as I try to emphasize before, you really have to determine what all your clients' needs are, and then talk to a healthcare navigator. And I think that they can help one decide what is the best program. I just recently had a client that just switch his plan because I suspected there were stroke or brain injury issues, and they went to the and I referred them to the Brain Injury Alliance, and so they gave him referrals, and all those referrals were outside of the assisting plan that he had. So he actually switched to a plan with Kaiser Permanente. So, but that was unique just for him. So those are things that you really have to look at as to what's the underlying issues, what are the treatment, who is very good at doing stuff. If it's one where you need to have all your specialists in one central area who are communicating with each other, as opposed to the client may just have one specific problem. So, you know, they can have medical coverage here, and I mean, their provider can be over here, and husband's doctor can be over there, and the children can be scattered around, and it doesn't really impact the individual service that each of them are getting. But that can be a problem if a client has more than one problem, and the medical care needs to be coordinated between 3 or 4 different specialists. So those are some of the things that you need to look to as well. And then you also look at who the providers are, just like anyone else. I mean, who's the doctors? I'm my own personal example. I got tired of my doctors kept switching, and I realized that they were like all under 35. So I actually found a primary care provider that has been in this place for 20 years. It's like a mid 50, you know, it's under 60. So I just know that I'm not going to worry about I'm losing this doctor. So those, I think, and so that's why I say, and we don't get into those kind of weeds, but that's something that case managers can work with the client and the healthcare navigators to try to figure out what works and what does not work. Does that answer your question?
Yeah, I think that for specific scenarios, it does get super complex. And I've just had families where a parent had a traumatic brain injury, but also had children with medical needs. And so it kind of gets super complex when there's family needs for coordination. And if, so it's like the parent needs case management support around their medical, but they also need support around their medical and then navigating their children's needs. And my previous program did that, but not long-term. Like we weren't a forever program. And so I've still never found something to fill that gap, to provide longer-term family-based support for both parent and children's needs around like care coordinating medical.
Well, I think, and one of the things you could ask the navigator is when they talk about family coaching, what does that really mean? If the managed care actually provides that, and if that is something the family coaching programs will do, then that may be a reason for selecting that plan over another.
All right. I think we've got a final call. We've got just a couple minutes, so maybe one last question. Okay, I'm going to put my final plug in for the post training survey. I'm going to stop the recording